Welcome to the deep dive. For years we've talked about this long-held dream of integrating artificial intelligence into medical practice.
Right.
The whole idea of AI expanding access to expert medical knowledge, medical reasoning. It's always felt like this beacon of hope, maybe, for global healthcare.
Definitely.
But what's been the biggest hurdle in actually, bringing AI into the really complex world of clinical diagnosis?
Yeah, that's a crucial question. I think the challenge has really been that most current evaluations of language models in medicine, they use these highly artificial conditions.
Okay.
Think about it. Static vignettes, multiple choice questions. It's like a textbook quiz, right? Not real life.
Right, yeah.
It just doesn't reflect how physicians actually work. Continuously gathering information, refining hypotheses, weighing all the evidence as it comes in. It's iterative.
So it's not just a simple one and done answer. It's more like a dynamic, evolving puzzle.
Exactly.
Okay, so our mission for this deep dive then is to really unpack a groundbreaking research paper. It's from Microsoft AI titled Sequential Diagnosis with Language Models. We're going to explore a new, much more realistic way to evaluate AI in diagnosis, and then introduce an innovative AI system that shows some, well, truly impressive performance.
And you'll discover how this research actually guides AI to, quote, think iteratively and act judiciously. That's the key phrase.
Ah, okay.
And that leads to both remarkable diagnostic precision and significant cost effectiveness. So this deep dive, it really offers you a shortcut to being well informed about the cutting edge of AI in medicine right now.
Let's start by digging into this new, maybe
Okay.
gold standard for medical AI evaluation. You mentioned iterative diagnosis. Can
Mhm.
you just explain what sequential diagnosis really means in a clinical setting? Why is it such a cornerstone?
Absolutely. So think of it less like that multiple choice exam we mentioned and more like being a medical detective.
Okay, I like that analogy.
Yeah, a physician starts with pretty limited information, right? Then they ask broad questions, which then lead to increasingly specific ones. They order tests, they analyze the results, and they adapt their initial ideas, their hypotheses as they learn more.
So it's a continuous loop.
It's a continuous loop, exactly. Inquiry and refinement.
And this is where the new benchmark comes in, right? The sequential diagnosis benchmark, SD bench.
Exactly.
What makes it so revolutionary compared to those static evaluations you mentioned earlier?
Well, SD Bench is revolutionary because it directly tackles those shortcomings.
Uh-huh.
It creates this interactive framework
Yeah.
that meticulously mirrors realistic sequential clinical encounters.
Okay.
And crucially, it measures not just the diagnostic accuracy, but also the cost of that whole diagnostic journey. That's
Wow.
a vital real-world factor that's often missed.
Yeah, hugely important. That's a massive step forward. So what kind of data powers SD Bench? Are we talking hypothetical scenarios or real patient cases?
No, these are real, complex, diagnostically challenging cases. SD Bench actually transforms 304 New England Journal of Medicine clinicopathological conference cases. NEJM-CPCs, they call them.
Oh, wow. The CPCs. Yeah, those are notoriously difficult.
Exactly.
Yeah.
Published between 2017 and 2025, and it turns them into these stepwise diagnostic encounters. And they range, from common conditions like COVID-19 pneumonia to incredibly rare disorders like neonatal hypoglycemia due to a biologically active teratoma.
Wow, fascinating. Okay, and how does a diagnostician, whether it's a human or an AI, how do they actually interact with these cases inside SD Bench?
So they begin with just a short case abstract. Like, for instance, a 29-year-old woman was admitted to the hospital because of sore throat and peritonsillar swelling and bleeding. Symptoms did not abate with antimicrobial therapy. That's it.
Okay, very minimal starting point.
Very minimal. And from that point, they can do three things.
Hmm.
They can ask free text questions, for history or exam details. They can request specific diagnostic tests like order a CT chest with contrast, or when they feel confident, they can commit to a final diagnosis.
I imagine ensuring realism is really key here. How do they stop the AI from, I don't know, cheating or
Yeah.
getting clues it shouldn't? Is that where the gatekeeper model comes in?
Precisely. Yeah, the gatekeeper model, which is another language model, like O4 Mini in this case, acts as an oracle for the patient case.
An oracle. Okay.
It only reveals findings when you explicitly ask for them. So it prevents spoilers, basically.
Got it.
But what's particularly ingenious, I think, is its ability to synthesize realistic findings for tests that weren't even described in the original case report.
Oh, interesting. So it can invent plausible results.
Exactly. Plausible, realistic results. This ensures clinical realism and stops the AI getting implicit clues just because some data is missing, which is, a common problem in fixed data sets.
Right. And once a diagnosis is proposed, how is it actually checked? Is it just like a keyword match?
Oh, not at all. It's much more sophisticated.
Yeah.
A separate AI model, the judge model, using the O3 model in their setup, evaluates the proposed diagnoses.
Okay.
And it uses this detailed physician-authored rubric. It's a 5-point Likert scale, so it scores the diagnosis from 1 to 5 on its clinical accuracy and, importantly, its substance.
Substance, right, not just the name.
Not just the name. A score of 4 or higher is considered correct, meaning, clinical management wouldn't really change based on that diagnosis. And the agreement between this AI judge and actual in-house physicians was remarkably strong. Cohen's kappa between 0.70 and 0.87.
That's a very high agreement. Sounds incredibly thorough. And you mentioned cost being a factor. How do they estimate costs within this benchmark? How do they discourage just ordering every test under the sun?
Yeah, they thought about that. Costs are calculated pretty rigorously.
Yeah.
There's a fixed cost, $300 assigned per physician visit, and multiple questions asked sequentially count as just one visit.
Okay, that makes sense.
Then the diagnostic test costs are figured out by another LM-based lookup system. It translates the free text requests, like order a CBC, into CPT codes, those standard medical billing codes.
Right, CPT codes.
And those are matched to 2023 U.S. health system pricing data. Now, obviously, these are estimates. They're not exact down to the dollar.
Sure.
But they provide a really consistent and fair way to compare the cost effectiveness of different approaches, whether it's human or AI.
Okay, so with this revolutionary benchmark established, SD Bench, the next logical question is, how did people and AI actually do? How did current AI models and even experienced human doctors perform on this challenge? What did that baseline reveal?
Yeah, this is where it gets really interesting. What truly stands out is how the experienced physicians fared on this difficult benchmark. They recruited 21 U.S. and U.K. physicians, mostly generalists, with a median of 12 years experience.
So seasoned doctors.
Seasoned doctors. Their average diagnostic accuracy was only 19.9%.
Well, less than 20%.
Less than 20%, at an average cost of nearly $3,000, $2,963 per case. They spent about almost 12 minutes, asked around 6 or 7 questions, ordered about 7 tests per case on average.
Okay.
Now, it's important they note a study limitation here, that these doctors were specifically told not to use external resources like search engines or UpToDate or anything.
Which is different from real life.
Which is absolutely different from real-world practice. So, take that performance with that grain of salt.
Right, but still a pretty tough challenge even for experienced humans under those conditions. And how did the off-the-shelf language model, the ones we hear about, how do they stack up against that?
Well, they tested a bunch of them. GPT-4o, O3, Gemini, Claude, Grok, Llama, DeepSeek R1. The usual suspects.
It's a whole lineup.
Pretty much. GPT-4o got 49.3% accuracy. Right. Better than the humans, but cost was similar, around $2,745.
Okay.
Interestingly, O3, another very capable model, reached the much higher accuracy, 78.6%.
Oh, wow.
And is but at a substantially higher cost. We're talking $7,850 per case.
Whoa. Okay, so we see a clear trade-off then. Higher accuracy seems to come with much higher costs for these standard unguided models.
Exactly. There was a really clear correlation between diagnostic accuracy and cost. Especially for those more capable reasoning models, they just tend to order way more tests.
Right.
And conversely, some of the weaker models showed what the paper called a false economy. They considered fewer possibilities, didn't order necessary tests, which was cheap, yeah, but led to lower accuracy.
So they saved money but missed the diagnosis.
Pretty much.
Yeah.
And this really raises that critical question. Can we actually get that high accuracy without racking up such prohibitive costs?
Yeah, that's the million-dollar question, or maybe the $7,000 question in this case. And that brings us perfectly to the really innovative solution they developed. They call it the MAI Diagnostic Orchestrator. What's the core idea behind this AI dream team?
So the MAI Diagnostic Orchestrator, or MAI-DIGX for short, it's an orchestrated system, and it was co-designed with physicians. That's important. The core concept is basically to simulate a virtual panel of doctors working together collaboratively, just like a real-world medical team might. So if you think about the bigger picture, MAI-DXO is trying to replicate the benefits you get from team-based clinical reasoning, catching biases, different perspectives, while also minimizing cost and invasiveness.
That sounds incredibly clever. So how does this virtual panel actually work? Is it like different AI models playing different roles, or is it one AI wearing different hats?
It's the latter. It's one single language model, but it performs 5 specialized roles. It essentially creates this virtual dream team all within itself.
Okay, what are the roles?
So first, there's Dr. Hypothesis. This role constantly maintains and updates a probability rank list of possible diagnoses, the differential diagnosis, keeping the top 3 most likely conditions sort of front and center.
Okay, the main suspects.
Exactly. Then you've got Dr. Test Chooser. This one strategically picks up to 3 diagnostic tests per round that it thinks will best help distinguish between those leading hypotheses.
Right, targeted testing. And what about the crucial part of challenging assumptions? Is there like a devil's advocate built into this AI system?
Yes, absolutely. That's Dr. Challenger. This role acts precisely as the devil's advocate.
No.
Its job is to identify potential anchoring bias,
Mm.
getting stuck on the first idea, highlight any evidence that contradicts the leading theory, and even propose tests specifically designed to falsify the current leading diagnosis.
Oh, that's smart. Actively trying to disprove the top idea.
Exactly.
Yeah.
Then you have Dr. Stewardship, who's all about cost, enforcing cost-conscious care, advocating for cheaper alternatives, maybe vetoing tests that are really expensive, but unlikely to yield much useful info.
The budget hawk.
Sort of, yeah. And finally, there's Dr. Checklist. This one performs silent quality control in the background, making sure test names are valid, checking for overall internal consistency in the panel's reasoning. Kind of the proofreader.
Wow. So these virtual doctors, they engage in this kind of internal chain of debate, you could call it, and then reach a consensus on what to do next, ask more questions, order tests, or make the call.
That's the idea, yeah. A structured deliberation.
So what were the results when they put this MAI DXO system using O3 as its base model to the test on SD-Bench?
The results were, truly remarkable. MAI DXO achieved 80% diagnostic accuracy.
80%.
80%. Now think about that. That's 4 times higher than the 20% average of the generalist physicians in the study.
Incredible leap.
Huge leap. And the cost savings are just as impressive. It cut diagnostic costs by 20% compared to the physicians.
Okay.
And by a massive 70% compared to that off-the-shelf O3 model running solo. Remember, that one cost $7,850.
Like the really expensive one.
MAI DXO got similar accuracy for just $2,397.
Wow, huge cost reduction.
Massive. And when they pushed it, configured it for maximum accuracy using some ensembling techniques, MAI DXO hit an astounding 85.5% accuracy and still kept costs lower than the standard O3.
That's amazing.
It really shows this isn't just some small improvement. It feels like it fundamentally redefines what might be possible for expert-level diagnosis, hitting both accuracy and cost efficiency.
And this is where the power of this structured reasoning, this internal debate, really shines through, right?
Yeah.
There's a specific case you mentioned that really highlights MAI DXO's ingenuity. Can you tell us about the patient who ingested hand sanitizer?
Yeah, it's a fantastic example. Really illustrates the difference. So in this case, you had a patient hospitalized for alcohol withdrawal, but they'd also ingested hand sanitizer while in the hospital.
Oh, dear. Okay.
The standard off-the-shelf O3 model, it kind of got fixated on antibiotic toxicity as the potential cause. Went down that rabbit hole, ordered expensive imaging, brain, MRI, EEG.
The works?
Pretty much.
Yeah.
Led to an incorrect diagnosis, and the cost was high, $3,431.
Okay, so expensive and wrong. And how did MAI DXO handle that exact same challenging scenario?
Well, in stark contrast, MAI DXO's doctor hypothesis, in the very first round of deliberation, flagged the need to consider in-hospital toxin exposures.
Broaden the possibilities
Right away. The panel then specifically asked the question, was there any hand sanitizer ingestion, which prompted a confession from the patient simulation.
Gotcha.
And that led directly to targeted confirmatory testing, just a toxic alcohol panel.
Yeah.
Result, correct diagnosis, and the total cost was only $795.
Wow. Less than a quarter of the cost and the right answer.
Exactly. It just perfectly illustrates MAI DXO's ability to actively seek out that disconfirming evidence to avoid getting anchored on those initial impressions, which is a common human cognitive bias too.
Absolutely. Okay, moving into the broader implications and the future outlook here, it's really impressive that MAI DXO seems to be, as they say, model agnostic. What does that actually mean for its potential impact across the whole AI landscape?
Yeah, that's a really key finding. It means this structured reasoning approach, this framework, it's remarkably versatile. It consistently improved diagnostic accuracy across all the different foundation models they tested.
Not just O3.
No, models from OpenAI, Gemini, Claude, Grok, DeepSeek, the Llama family. All of them saw a boost, an average of 11 percentage points in accuracy.
Wow.
So it suggests the framework itself, the structured debate, helps even maybe weaker or less specialized models overcome some of their inherent limitations.
That's powerful. So when we talk about this kind of superhuman performance, maybe in quotes, it really does challenge our traditional understanding of medical expertise, doesn't it? Is AI essentially creating a new kind of medical specialist here or something else?
It absolutely challenges it. These frontier AI models, especially when structured like MAI DXO,
Mhm.
are showing both incredibly broad and deep medical understanding. They seem to combine, as the paper puts it, the generalist's range with specialist's depth. So you can almost think of them as acting like an entire hospital-like team rather than just a single doctor.
That really raises an important question then, doesn't it? When we evaluate these really advanced AI systems, should we even be comparing them to individual physicians anymore? Or should the benchmark be, like you said, entire hospital-like teams of generalists and specialists?
Exactly. How we frame that comparison seems like it will profoundly define AI's future role in healthcare. It sets the bar.
And the real-world impact potential here feels immense, connecting right into some urgent challenges we face in healthcare delivery globally.
Oh, definitely. I mean, consider the potential for just expanding access to expert-level medical knowledge around the world.
Oh,
Think
wow.
about mitigating the costly impact of clinical workforce shortages.
Yeah.
And even potentially down the line, direct-to-consumer tools.
Yeah.
Maybe smartphone-based triage, especially valuable in resource-limited settings. Of
Mhm.
course, huge caveats there around safety and regulation.
Of course, yeah. Big hurdles there. But the potential is clear. Now, naturally, no study is perfect. What are some of the limitations or caveats we should keep in mind when we're interpreting these really groundbreaking results?
Yeah, they're good about listing them. It's important to remember the NEJM CPC cases, while they're excellent for teaching and pushing boundaries, they are complex. They're curated. They don't represent typical disease prevalence you'd see in a normal clinic.
Right, no healthy patients, for example.
Exactly. Also, those cost estimates we talked about, they're first-order approximations. Other really important factors like, how invasive a test is, patient discomfort, wait times, those aren't captured yet.
True, real-world costs are more than just dollars.
Right. And as we mentioned earlier, that physician performance assessment was constrained, no external resources allowed, which, again, differs from how doctors really practice.
Got it. So, acknowledging those limitations, what does this all mean for the future of medicine? Beyond just diagnosis, what sort of possibilities does this open up?
Oh, the potential feels vast. Imagine using systems like this to enhance medical education and training, letting students and doctors refine their diagnostic reasoning in these interactive simulated environments.
Like a flight simulator for doctors?
Kind of, yeah. There's also a clear need now for diagnostic data sets that better reflect real-world disease prevalence, not just the super complex cases. And then the really exciting prospect of incorporating visual data, maybe other sensor modalities, into AI diagnosis, moving beyond just text.
Yeah, adding imaging, pathology slides.
Exactly, making it even more comprehensive.
Wow. This deep dive into sequential diagnosis with language models really feels like it reveals a pivotal moment for AI in medicine. We've seen the crucial need for more realistic ways to evaluate AI, like SD-Bench, and then witnessed this breakthrough dream team approach of MAIDXO achieving not just, well, superhuman accuracy in this context, but also impressive cost efficiency.
It really makes you consider how AI, especially when it acts like this highly coordinated team of medical experts, could potentially redefine not just the act of diagnosis, but maybe the very structure of healthcare delivery itself.
Imagine that future,
Yeah.
where maybe human physicians are freed up somewhat, able to focus more on those truly human elements of care, the empathy, the communication, the personal connection. While this technology helps foster more equitable access to high-quality medical expertise worldwide, it truly makes you reflect, doesn't it, on the profound implications of these advancements for your own understanding of AI's transformative role in the future of medicine.